Welcome to Community Cares and Project Echo. Today we're doing a session on financial wellness and survivorship. So thank you for joining today's session, and we hope that the information shared today will help you serve your community better. I just have a few announcements before we begin. So this is just a quick disclaimer that the information contained in this
Sarah, we don't
presentation.
see the presentation. Does anybody else see the presentation? Is it just me?
I can see it.
Oh, I'm
I
sorry.
see it. I see it.
Okay, I must have done something. Sorry.
Maybe it's in a different window. I don't know. I can try. Do you want me to restart it? Let me see.
No, you're fine. It was user error on my part.
This is just a quick disclaimer that the information contained in this presentation is not a substitute for a medical consultation, and the physician should always be consulted for any health problem or medical condition. So this is today's agenda. We're going to do a Project Echo series overview, introductions, the actual presentation and case study, and then we'll do questions and answers at the end. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can visit echo.unm.edu. And so for today's presentation, we have Dr. Boschman. Dr. Boschman is an assistant professor of nursing and the scientific lead of cancer delivery research for the Herbert Irving Comprehensive Cancer Center's Minority Underserved National Cancer Institute Community Oncology Research Program at Columbia University. She serves as vice chair for cancer care delivery research in the Children's Oncology Group. Clinically, she has practiced as a pediatric oncology nurse practitioner for over 15 years. She uses mixed methods and pragmatic studies designs to develop, test, and implement interventions to identify and address financial and health-related social needs during and after cancer treatment for children, adolescents, and young adults. So I'm going to pass off the screen sharing to Dr. Boschman. And I'm really excited for this session because we haven't ever covered financial wellness. So welcome, Dr. Boschman. I'm going to stop sharing my screen and I'll let you share yours.
Great. Thank you so much, Sarah, and thank you so much for the invitation to join you all today. I'm really excited to talk with you all about some of the work that we've done screening for financial hardship and then developing interventions to address it. Can you see my screen correctly now?
Yes,
Wonderful.
we can see your screen, the slides.
Great. So I'm going to talk about implementing and evaluating financial screening in outpatient oncology clinics. Thanks to Sarah for the great introduction. I have no conflicts to disclose. And just a brief overview for today. So I have some background definitions just to sort of frame us all on the same page. And then I'll talk about the work we did first where we started screening for financial hardship in breast oncology, and then expanded to include health-related social needs screening and to focus on younger patients. I'll talk just briefly about some of the intervention work that we've been doing, and then we'll have a case study and have time for discussion and questions. So just briefly, and Sarah gave a great introduction, but I feel like it's always helpful to hear where people have come from. I went back for a second degree in nursing. I went to Columbia for the program and then worked as an inpatient staff nurse on an inpatient pediatric oncology and bone marrow transplant unit, and then worked as a pediatric oncology nurse practitioner where I got more involved with clinical research through the Children's Oncology Group, as well as the NCI's Community Oncology Research Program. And I realized, especially in pediatric oncology, most kids are treated on clinical trials. And so I really got interested in research, how we can use research to improve care delivery and potentially improve outcomes for young people. So I went back to school for my PhD at the School of Nursing here at Columbia and was on a training grant where I was able to get exposed to more informatics training, thinking about using the electronic health record. And then I did a postdoc in the epidemiology department at the School of Public Health, and then joined Columbia faculty in 2021. So again, just to, I think probably many of us are familiar with these topics and definitions, but just to put us all in the same place. Health disparities are not just any differences in health. The World Health Organization defines them as avoidable differences that arise from the social and economic conditions that determine an individual's risk of illness and the actions that are taken or perhaps not taken to prevent or treat said illness. With the goal really being health equity, which is the state in which everyone has a fair and just opportunity to attain their highest level of health. And this figure here highlights populations in the US that experience cancer disparities. So you can see there are unfortunately multiple groups, and most of my work focuses on younger patients, as well as those who identify from underserved racial and ethnic and socioeconomic communities. So social determinants of health, social risks, and health-related social needs are related but distinct terms that we use in this space. So the determinants of health are those broader conditions in the environment where people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of daily life. Whereas social risks are the presence or the exposure to adverse determinants of health or social drivers of health. Health-related social needs are the individual or household level social risks for which an individual may seek or receive help in addressing things like difficulty affording transportation, food, housing, other forms of financial strain. And these needs, if unmet, can lead to decreased health and a lower quality of life. And this figure here is from Healthy People 2030, just showing you the different domains of social determinants of health. And you can see how each of those can sort of relate to the individual level if not addressed. So financial toxicity is a term that is increasingly used in the healthcare setting. I think it's a charged term because I think it captures your attention, but it's meant to describe the harmful effect of the high cost of treatment on a person's quality of life. And it's increasingly recognized as a really important part of health outcomes and affects many, over 130 million adults in the United States annually. And this figure here just shows, it's from JAMA Oncology Patient Perspectives. It just sort of shows you how the financial costs of care impact patients and families, which probably many of us are familiar with. So what is it and how do we measure it, right? In research, if we want to do something about it, we have to figure out how we're going to measure it. So there are three pretty well-established domains of financial toxicity. And you can see this figure here was first described in 2015 by Dr. Tucker Seeley, and then this figure itself was published in 2016 by Dr. Altice and colleagues. So the material conditions are those concrete out-of-pocket costs, as well as the indirect costs that one may incur when they can't work the usual hours that they would work, or if they lose their job or have decreased income. The psychological response is that worry about the cost of care that one may experience. And then the coping behaviors are what one does in response to those costs of care. So these can be clinical or sort of health-related coping behaviors, such as skipping medications, spacing out appointments, not coming in for follow-up. But they can also be things like financial coping behaviors, maxing out credit cards, depleting savings, things like that. So the terminology and measurements vary. Sometimes we think of the more objective measures. How much did you pay out of pocket, for example? There's also questions that assess your ability to cover the costs of care. So how hard would it be for you to afford a $2,000 payment, for example, is a question that's been used. And then there are validated measures of financial toxicity and financial distress, including the cost score, which is the comprehensive score of financial toxicity, which was developed specifically in the cancer space. And there's also the personal financial wellness scale, which is not cancer specific, actually not even healthcare related specific. It was developed in the economics literature, but is a well-validated tool. However, even with these uncertainties about measurement, screening is recommended by many organizations in the United States, including in adult oncology as well as pediatric oncology. And so the gap that I'm really interested in is how do we screen? Who do we screen? With what do we screen? And then what do we do when we identify a positive screen? So just to shift gears quickly to a younger population, adolescent and young adults are an important population that's increasingly recognized as vulnerable to poor cancer outcomes. There are over 85,000 AYAs diagnosed annually in the United States with cancer, and most of them, more than 80%, are expected to become long-term survivors. This is probably even more than 85%. The NCI does designate them as a vulnerable population due to their high risk of second cancers. They have a high risk of treatment-related morbidity and mortality, and then, of course, mental and social health sequelae. Many of them survive, but they go on to live many years sort of in that survivorship setting. There are also known disparities in access, treatment, and outcomes within this population. So AYAs who are Black, Hispanic, poverty exposed, or have public insurance have been demonstrated in many studies to have poorer event-free survival as well as overall survival. And this has been observed across multiple tumor types, which suggests that social determinants of health and unmet health-related social needs may play a role. So financial hardship in AYAs. AYAs do experience as much as twice the rate of financial hardship compared to older cancer survivors. They don't have that savings, right? They're sort of in this vulnerable stage of establishing their careers, finishing school, trying to get jobs. And so this has been shown consistently. And compared to AYs without cancer, AYs with cancer report significantly more medical financial hardship, which of course makes sense given all of their healthcare costs that they incur. And those who are younger with lower income or publicly insured are more likely to go into debt or file for bankruptcy, which has been shown to be an independent risk factor for earlier mortality. So it's a vulnerable group of cancer survivors. And then thinking about the broader social risks and health-related social needs, we know that AY survivors are more likely to be unemployed compared with their peers, and that unemployment and financial hardship have been linked to psychosocial outcomes, including anxiety, depression, as well as pain. Conversely, right on the good side, being employed is independently associated with better quality of life. And so the idea behind much of the work we do is that the risk and trajectory of lower educational attainment, unemployment and financial hardship, and even poor health outcomes among AY survivors are likely strongly influenced by adverse determinants of health. So financial toxicity, if we want to, it's a modifiable factor. So by addressing it, we may be able to improve and address health-related social needs and ultimately improve health outcomes for this group. So the two gaps that our work focuses on here are first screening for financial toxicity and health-related social needs, and then what do we do if we identify it? So I'm first just briefly going to talk about some of the work we did in the breast oncology space. And this was during my postdoc. We received a grant to develop and implement financial hardship screening in our outpatient oncology setting, with the idea that implementation of routine financial screening was a really important step toward mitigating financial toxicity. That screening would then facilitate identification and then earlier intervention delivery. So the objective of our study was to develop a financial screening process using stakeholder input, and then evaluate the feasibility and acceptability of this screening in a large urban cancer center. So we developed our process through key stakeholder input to identify both the screening tool as well as the screening process. And the figure on the right shows you the Consolidated Framework for Implementation Research, or the CFIR framework. This is a really helpful implementation science framework when you're thinking about planning how to implement an evidence-based strategy into a clinical or other community setting. And so we use this framework to help develop our process. We were focused on English or Spanish-speaking patients who were 18 and older who were treated in the breast oncology clinic during the 1-year time period of the study. And our survey data collection was through either the patient portal, which I'll talk about in just a second, or through paper forms that would be manually entered in the electronic health record. We also wanted to assess the perception of screening, both from patient perspective as well as clinician perspective. So we did conduct structured interviews to understand this better. So our process for screening, and again, this is through stakeholder input, was determined to be first for patients, sorry, man. Oh, sorry, there we go. For patients who checked in online for clinic, so if you sometimes get a prompt to log in through your portal, those patients would during that process be prompted to answer 2 questions, which was 3 clicks. And then when they arrived to clinic, there would be no flag in the electronic health record. Those who didn't complete this pre-screening online would arrive to clinic. There was a flag that would notify the front desk staff to give them a piece of paper. They would answer the form. And then during vital signs assessment, the medical assistant could enter the the responses to the 2 questions into the electronic health record. So our screening tool, we also had to determine this with stakeholder input. We looked at the 11-item cost measure. There's actually a 12th item as well, but at the time there were only 11 items, and the 12th item doesn't go into the full scoring. So we looked at those. It was very quickly clear to us that we couldn't implement an 11-item screening tool in a busy clinic. So we heard very clearly that 2 items would be really the max that they thought was feasible in the clinic. And this was from the front desk staff, the nurses, the physicians, the administrators. We did talk to patients as well. So we selected 2 items from cost, one positively worded and one negatively worded. It's a pretty, it's a unidimensional measure, meaning that all of the questions are quite similar to each other. So we felt like it was justified to select 2 of the items. And then we did conduct a secondary analysis to understand how well those 2 items performed compared with the overall measure, which was administered to a subset of patients in clinic. So this shows you the screening tool. These are the 2 questions. The first one is, I know that I have enough money in savings, retirement, or assets to cover the cost of my treatment. And the second is, I worry about the financial problems I will have in the future as a result of my illness or treatment. This shows you the Spanish language version. And we wrote this up just to understand how each of the 2 items performed in a separate, smaller paper. So of 3,500 patients that were treated in clinic during the study period, we had a 39% response rate, which we felt like was okay for the first year of implementation. Comparing that overall response rate of 39%, we saw that AYs were significantly more likely to respond compared with older patients who were over the age of 70. However, we did identify that there were groups who were less likely to respond, including those who spoke Spanish, those who identified as non-Hispanic, Black, or Hispanic, which highlighted some areas for improvement in the subsequent implementation periods. We also spoke to patients about the screening. They felt overall like it was, they were supportive of the screening. They thought the topic was important, but they wanted to understand really transparently why this was being conducted and where their responses would be, what their responses would be used for. There was an importance of making sure that the non-English questions were implemented seamlessly. There were some glitches in the EHR in that first year of implementation that didn't always there was some, it didn't always show the language of preference for the patient when they were in their portal. And then when we spoke to staff, they felt like this was important, but they were really concerned about the limited resources that were available in staff, and especially this was during COVID, during a busy clinic period. And they were concerned about the paper forms. The distribution was really challenging. They did highlight that kiosks or other patient-directed support may help improve technology engagement. So overall, we felt like systematic financial screening is feasible. However, we learned some lessons through the implementation science framework, which was really helpful to help us have a broader understanding of this implementation project. It really requires engagement with clinical staff, providers, and patients. And it highlighted the need to offer low-tech screening options wherever possible. So this was published in a journal a couple of years ago. But more importantly, it sort of prompted us to think about how we can do this in other clinical settings. So we continued the implementation in the breast oncology clinic, but we wanted to focus on younger patients and also expand to include health-related social needs screening across multiple clinic settings. So we adapted this process to focus specifically on adolescent and young adults. And we used a different implementation science framework, which I won't go into great detail, but it's called the REAIM framework. And it's really helpful for evaluating an implementation. So the first one is helpful for planning, and the REAIM framework is helpful for evaluating. So we replicated the process that was implemented in the breast oncology clinic and adapted it to the pediatric and hematologic clinic settings. We also added a social determinants of health or health-related social needs screening tool that had already been implemented in our hospital system. And you can see this on the right here. It has the 2 pretty standard questions to assess food insecurity, 2 questions about transportation, 3 questions about housing, although we did recently drop the middle question, and then a question about unanticipated ED visits. We partnered with the EPIC team to optimize our Spanish language portal views, and we did conduct semi-structured interviews to assess patient and caregiver perceptions and barriers to screening. So we implemented this in November of 2022. I just want to take a quick second to talk about how we determine a positive screen, because it's not always as well established. For the health-related social needs, it's pretty clear from the literature. Most of these screening items are validated. And you can see here, if they say sometimes or often, they're considered positive, or if they say yes for the other questions. With the financial hardship questions, we considered the top 2 most severe responses to be screening positive. And this has been done in other studies using cost as well. And we're, again, continuing to assess the validity of these items. So this just shows you the process for our refinement into the AY setting. So we focused on patients who were 15 to 39 with at least 2 encounters in one of the 3 outpatient oncology clinics, and then looked at these same 2 screening items and using the similar process that was implemented in the breast oncology clinic. We spoke to stakeholders who I mentioned previously, and then we decided, as I said, to use the portal-based screening and offer paper options where available. However, this has continued to be a challenge due to human resources and time constraints in a busy workflow. So we're continuing to figure out how we can ensure that the screening is accessible to everyone, even people who don't use their patient portal. So the REAIM framework, the R is reach, and reach we defined as the proportion of AYs or caregivers who complete the screening compared to those with encounters in the same clinical setting who did not complete the screening. And we primarily evaluated this using the financial screening questions as the denominator. We used descriptive statistics to look at the proportion of responses. And overall, we had a response rate of 50%, which was a little better than our breast oncology response rate. We were hoping for closer to that 60% that we saw just in the AYA group. We again looked at AYAs who had more than 1 encounter in these clinics. We were trying to avoid screening patients who were just coming for a consultation and maybe overwhelmed with many other information overload and other things on their plate. If they had responded to any financial screening item, they were included in the analysis. And you can see here, these are the sociodemographic factors that were associated with responding. So not with financial hardship, but just with responding. So we did see that we had a significantly, or the non-Hispanic white patients and the Hispanic patients had similar response rates. And so we improved with that patient population. However, we still had lower response rates in our patients who identified as non-Hispanic Black or had not determined their race or ethnic group. Similarly, we saw lower response rates in those who spoke Spanish or, of course, other languages, because the other languages have not yet been established in EPIC. And we did see lower response rates in males compared with females. But overall, we did see an improvement in reach of screening in certain groups that previously had lower response rates, particularly the Hispanic AYAs in the clinical space. So effectiveness is the E from the REAIM framework, and this we defined as the identification of financial hardship using our screening process. Again, we use the 2-item cost instrument and also the 8-item health-related social needs instrument. And we use descriptive statistics and chi-square to look at demographic factors associated with financial hardship. We also explored different health-related social needs domains and associations with healthcare utilization, including ED visits, visits to the emergency department, and hospital admissions. So most who completed the screening responses completed both items. We saw that 41% endorsed financial worry. That question, I worry about the problems I'll have in the future. And 73% endorsed financial hardship, which is that I know that I have enough in savings to cover the cost of care, which I think makes sense, especially for the younger patient population. And we're still trying to figure out if these are the right 2 screening items, or if we need to add a 3rd item or modify our items. Overall, 66% of respondents screened positive to either question. And this shows you factors associated with financial hardship. So our patients who are Hispanic were significantly more likely to endorse financial hardship compared to those who are non-Hispanic white or non-Hispanic Black. Patients who spoke Spanish also were significantly more likely to experience financial hardship. And males were just slightly more likely than females to experience financial hardship. This just shows the comparison between patients AYAs with food insecurity, that's what the FI stands for, and without food insecurity. and similarly, patients with financial toxicity and without financial toxicity, and then looking at their ED visits or hospitalizations. So overall, AYAs with food insecurity were significantly more likely to have ED visits compared with AYAs who did not have food insecurity. And this was significant with a p-value of less than 0.01. Hospitalizations were different, with AYAs with food insecurity having more hospitalizations, 39% compared with 31%. However, this was not statistically significant. And we saw a similar trend in the analysis looking at AYAs with financial toxicity, where 26% of those with financial toxicity had ED visits compared to 17% of AYAs without financial toxicity. But again, this was not quite statistically significant, but shows you the proportional differences between groups. And then adoption is the A in REAIM, and we defined this as the response rate by a specific clinic location. So we had 3 participating clinics at the time when this paper was written up. We've expanded to include a few more since then, and 1 initiated screening much later than the first 2. Obviously, breast oncology had already been implemented. Pediatric was the second, and then the hematologic clinic was the third. And we looked at early evaluation of adoption as we consider expanding to other clinical settings. So this shows you the cumulative responses, the proportional responses over time by clinic setting. So in the red line, you can see the breast oncology group had the highest, and then pediatric oncology second, and then the lymphoma clinic was third. And then implementation is the I in REAIM, and we conducted semi-structured interviews with patients and caregivers to assess the implementation. So we completed 3 interviews with a patient and caregiver. 10 were conducted in Spanish and 14 in English. And overall, we heard that it was important to have multiple options for screening. For example, the portal, but paper, but also in person. And often our social work team was conducting these assessments in person, and they talked about how they often like that. Although a few people said I would prefer to do this in the privacy of my own home and not have someone ask me face to face. So a flexibility is certainly one of the things that we hear often. And as I said, some preferred to have these asked in person, others preferred the portal. And most felt comfortable answering the questions. They just wanted to know what the information would be used for, which of course makes sense. So there are obviously limitations with our screening analysis. The screening processes vary across clinical departments. Some clinical departments have more resources and are able to implement the paper screening better than other clinical settings. The timing of the screening and the clinical trajectory also varies. So some patients may be early in treatment, some patients may be into survivorship, or sort of in palliative care, approaching more like hospice care. So there's a lot of variables that we can't yet account for in the data as it is right now. One of the most important things is balancing our screening reach. So we want to make sure that we're screening as many patients as possible, but we also want to be mindful that we can't always respond to every positive screen. And so figuring out that balance is something that our team talks quite a bit with ourselves as well as with the clinical teams. Because interventions are only available for certain patients in certain settings. And so figuring out, even if we don't have a full intervention available, what resources can we provide through the portal or a paper form, things like that, that we know are already happening. We partner with our social work team very closely. So building out the resource sheet that they're already using and figuring out how to get that to patients who screen positive is one of the sort of low intensity responses that we've developed. And then, of course, many are not screened in this process. And so we suspect that the positive screens proportions are likely underestimated. There's, of course, measurement challenges for financial hardship in particular. And we're continuing to refine our strategies, especially with multimodal screening procedures. So one of the things that we're focused on is leveraging technology. I won't go into great detail, but obviously scaling this becomes a huge impediment when we think about this across multiple busy outpatient clinical settings. So figuring out how to leverage technology, but also not worsen disparities that already exist, and being mindful of when we use technology, but where we need to supplement that with human delivered responses. So we're thinking about this from a learning health system approach, which I won't talk about in great detail, but I just wanted to mention this. A learning health system is increasingly thought about when we think about health systems and healthcare as a promising approach that improves internal data collection and evidence generation by integrating findings with external evidence. So really trying to be in more real time, using the data that we're collecting from patients in the healthcare setting and integrating that with the evidence that comes that's published to really improve our care delivery system. And so figuring out how to be mindful of technology in that space is something that we're focusing on. I'm not going to present the data on the pediatric population, but I shared the QR code for the paper that we published in this space. We did a similar study where we implemented financial screening and health-related social needs screening just in the pediatric clinic, and we have data on all of the age groups, so not just the 15 to 39-year-olds. And we found similar high rates of financial hardship. And in that study, we were actually able to identify where the screening was conducted, if it was the portal, if it was through the social worker team or other healthcare team members, or if it was done by paper. And so we're really trying to understand better how to use resources in the best way that we can and be mindful of people's busy workflows, but also not duplicate screening. So if a patient responds in one way, that they wouldn't be prompted to respond another time, or at least not for a period of time. So those are some of the lessons that we're learning in the pediatric space. So just briefly, I wanted to mention, because I want to get to the case, what we do when patients endorse financial hardship and health-related social needs. So there's a lot of work happening in financial navigation intervention development, health-related social needs navigation development. Some of these show promise, but most have not been developed for younger patient populations. And so we conducted a qualitative study where we spoke to younger adolescent and young adults and caregivers in English or Spanish to understand what their experiences looked like and what they wanted in a navigation intervention. So these were the three themes that we identified: the burdens that they experience, but also the supports that are so important in helping manage those burdens. And then they offered some really helpful advice to tailor the interventions for sustainable and effectiveness. So from those lessons, we developed what we call AYA-NAV. We first tested this in a single-arm pilot study. This is an AYA-tailored needs navigation that's in collaboration with our community partner, the Patient Advocate Foundation, who offer excellent case management services. And we adapted this from the adult-directed model as well as our qualitative research findings. And that we just are submitting the revisions for that paper for the single-arm pilot, but we did observe a significant improvement in financial toxicity scores over 6 months in the participants. We also adapted that intervention for caregivers of younger patients because we heard early in the single-arm pilot that for the younger patients, those caregivers really had different needs, and the Patient Advocate Foundation often they're more familiar with the addressing needs of the adult patient who has healthcare needs. And so figuring out how to partner with other organizations who are more used to helping caregiver needs is a focus of this next iteration. And then we are now testing the AYA-NAV in a randomized pilot that's funded through an R21. And this is just a brief schema of what the intervention looks like, but essentially we pre-screen adolescent and young adults for financial hardship and health-related social needs. If they screen positive, then they're eligible, and then we stratify them by younger age group and older age group, and then they're randomized to receive AYA-NAV or usual care, which is that digital or paper form of resources that I talked about that we've adapted with our social work team. AYA-NAV includes after the baseline screening, then they are referred to findhelp.org, which used to be called Ambertha, which many of you are probably familiar with, is an online platform of community resources that may be helpful in addressing health-related social needs. We also, if they meet certain criteria, refer them to the Patient Advocate Foundation. Through the single-arm pilot, we learned a lot of lessons about who the best candidates are for their case management services. And then we also offer a vocational guidance session to the younger AYAs, again, based off of that early finding that the caregiver and younger AYA needs were a little bit different. And then we conduct check-ins at month 3 and month 6, and our primary outcome is at the end of the study. We do also offer a voucher at baseline to address those immediate concrete needs, such as perhaps affording groceries or Transportation, recognizing that $200 is not a lot, but it may help alleviate those immediate needs to help them get to clinic or something like that. So I don't know, should I pause for questions or should I go straight into the case?
We can go into the case and then we'll do questions after.
Perfect, great. So thinking about this population, I want to present a case of Jude. So Jude is a 24-year-old man with no significant medical history who presents with several weeks of night sweats. He's also having intermittent fevers, he's increasingly tired, and he has diagnostic imaging and biopsy that confirm lymphoma. So he started on a combined chemotherapy and immunotherapy regimen for 4 planned cycles. And early in treatment, the oncology team notes that he misses appointments often, he arrives late to appointments. When they ask him initially, he gives brief answers. He's just, I'm busy, it's fine. He doesn't want to request for support, and he's really not engaging in some of those discussions. And they get frustrated because they think, why isn't he coming to these appointments? This is, it's a very curable cancer. He has 4 cycles of treatment. He, may need radiation after, but that's all to be evaluated. But he's not able to make it all the time. So over time, they start to build trust and rapport. They talk about underlying contributors. They sort of understand more clearly what's going on. So Jude is working 2 jobs. He's working 1 part-time position that provides his insurance coverage that he needs to afford treatment. And then he also works in a delivery job that helps to provide extra support so that he can pay some basic expenses. So his work hours are long, often unpredictable, and he fears his job loss, especially the one that covers his insurance, if he discloses his diagnosis or misses work. His treatment appointments often conflict with his shifts, and transportation becomes a challenge on the days that he works back-to-back jobs. His living situation is also tricky. He lives in a small apartment with 3 roommates. He has limited privacy. He doesn't have a lot of emotional support, although they are his friends. So he shares frustration as, again, the team builds rapport and trust with him, that his friends are advancing their careers, they're enjoying, their young adulthood life, and he feels stuck. He's really tired, he's financially strained, he also is sick. So he avoids asking for help out of worry that he'll be judged or just seen as not able to manage the things that are happening. So his care trajectory, I think this is sort of a typical case that we have seen, and I've seen in my clinical roles. That 18 to 26-year-old who often has a very curable cancer and comes in for treatment, and they can't get there for appointments. They're not showing up. They're not really engaged. Sometimes, though, if you can find that person in the healthcare team who can get them to talk, that's where it sort of all can open up. And that's where you can find out that they're, working all these jobs. Often this is usually our social work team who are able to unpack some of this with us, or our psychologist. But I think that this type of case highlights the role of social determinants of health. In this case, Jude is experiencing employment insecurity, financial strain, inadequate social support. He has transportation difficulties. He also has an unstable housing dynamic, even though he has housing. In this age group, right, when you're living with multiple roommates, there may be infection concerns, there may be other challenges. So his inconsistent appointment attendance really reflects the structural challenges and probably less likely his lack of motivation. So by identifying these factors, the care team then can collaborate with Jude to adjust their appointment times. Often they can connect him with social work if he's not already connected. If there are financial counseling services available, that's always something that should be offered if it can be offered. He would, of course, be a great candidate for the AYA navigation study. But the first step, of course, is asking about the financial concerns, and then recognizing them, and then referring for support that might be helpful. The other thing, I think, just to highlight the importance of mental health support, because the financial and mental hardships that these patients in this age group in particular go through, though they're different, they often come together. So making sure that the financial concerns are assessed and, if possible, addressed, but the mental health concerns are also assessed and, if possible, addressed. So I had a few discussion points that maybe we can come back to for the Q&A, but I did just want to briefly say some key takeaways. I think this talk has shown that financial burdens and unmet health-related social needs are really prevalent, particularly in younger patients with cancer. And so we need interventions that are effective, feasible, and sustainable across multiple clinical settings. Screening can be used to match patients with health equity interventions, such as a navigation intervention, and we're using this approach now to screen patients and then match them for these navigation interventions. But we need to be mindful of balancing technology screening and in-person outreach, again, for the resources that it requires and the strain on the workflow, but also for the feasibility of patients who might not be using technology. We don't want to worsen current disparities. Measurement, of course, remains a challenge, but there's a lot of work happening in that space. And then I think just to close with the thing that we hear all the time, and I think you probably hear in your communities, is patients want to talk about this. They are aware of the financial costs. I remember 5 or probably even closer to 10 years ago when we were first talking about this in the research setting and talking about studies where we would implement systematic screening, and there were concerns, but quickly the patient said, no, this is something that we really want to talk about. We have to talk about this. And normalizing the conversation, it's not a rare occurrence, unfortunately, that patients experience financial hardship. In fact, it's the majority of patients. And then being mindful about follow-up and managing expectations. We often assess for housing instability, and housing is a really tough one to solve, right? So saying, I'm going to ask you these questions, I may not be able to help you today, but we're hoping that we can refer you to resources that may help, hopefully in the short term or at least in the long term. And then, of course, partnering with the community organizations is critical, and understanding our what we can and can't do, because, of course, just like healthcare settings, the community organizations also have limitations of local resources. And then I just have my thank you slide. I've been the recipient of incredible mentorship and a really fabulous research team that we've built, and our community partners and the funding that helps this work get done. And I have some references here as well if they're helpful.
Thank you so much. And all of this will be posted in our Mighty Network. So if you missed anything or you want a QR code, it'll all be posted. Since you have your slides up right now, we can do questions. Thank you for presenting. That was amazing. I have a few questions too, actually. I see we have one from Janet. She asked if increasing more oncology social workers would help, or are social workers not providing adequate resources to AYAs in need?
Yeah, so Jenna, it's a great question. So I think probably more oncology social workers will always help. I think we always say, I think we should have as many social workers as we have nurses, because the needs are so great in this patient population, and especially as our healthcare system becomes more complicated and more expensive. A few of the studies that are developing navigation interventions often work with the social work team that is already in place, and just provide additional training. So there are, and you might already be aware of these, but there are trainings for financial navigation that often social workers can, that they participate in. They're, I think, anywhere from free to low cost, and some institutions are actually covering the cost of those trainings. I think they range from, a half a day to a 6-week course. But there's a lot of information that's out there that's available. I think that the thing that is most important is making sure that we're systematically asking so that we identify people. I'm sure in your experience too, you've seen the cases where everyone says, oh no, that family's fine, or that patient's fine, they don't have financial strain. And then 2 months later, they're not able to get to clinic because their car broke down and they can't fix it, or they can't afford their medications. And so these things change over time. So making sure that we're assessing at intervals is another really important part. And of course, that takes manpower, right? That takes people who can ask the questions and then who can follow up on the responses. Thank you, Jenna.
Katie also has a question. Do you think that a lot of these individuals need more, quote, hand holding, and that to obtain the resources that are available can be overwhelming?
So I think the thing that one of the things that we're trying to do is to figure out like a dose level, if you will. So even just in our early work with the AY navigation studies, some patients are very good at taking those resources. They follow up with the Patient Advocate Foundation. They call the resources on findhelp.org. The organization calls them. They're able to address. They get access to, to food services or whatever their other needs are. Other patients are a little frozen, right? There are other stressors. They don't have a lot of social support. And so figuring out who we can say, here's the information, let us know if you need more help versus you're going to need more help because we already can tell that you are struggling, you don't have social support. Understanding how to stratify the different the doses of the intervention are really important. Because certainly the other thing that we've seen in the for the caregivers of the younger patients is I think for the parents of the younger the pediatric patients, they're sort of in crisis mode. Their whole household is just trying to keep it together. And so we found for the patients who are treated in adult oncology, they'll answer our phone calls, they'll call us back, they'll text us back, they'll follow through, most of them, not all. Whereas in the pediatric clinic, we need to go to them and meet them in the clinic and say, okay, you're here. What can we help you do while we have FaceTime with you? Because once they get home, they're dealing with other family members, other siblings, other school concerns. And so I think all of those factors are important to assess because I think that it depends. I think some people really do need hand holding and other people have that sort of resilience and ability to advocate for themselves.
I had a question too, actually. This is like towards like the beginning of the presentation. I know we talked about like, the questionnaire. I just wanted to ask, because you went from 11 questions, you had to narrow it down to 2. So what was like the key criteria when you were considering which 2 questions to keep?
So the key criteria was that it would only be 2, and then the other, it was really a very iterative discussion-based approach, because and so the 11 items, if you look at things like a factor analysis, they all are very tightly associated with each other. So you probably can ask any 2 questions out of those 11 items, and it will give you a reasonable ability to identify someone with financial distress. We decided to choose one that was negatively worded and one that was positively worded, and one that looked a little bit more at the financial worry or the financial distress, and one that was a little bit more concrete ability to pay for the cost of care. I will say, so we've actually just recently added the 12th item, which is my health related illness has been difficult for my family or for me and my family. I think that's the wording. Sorry, I don't have it right in front of me. And that question, a recent study was just done that showed that using that 12th item is actually very strongly associated with the overall 11 item cost score. So you can actually just use a single item as well. So that's how we got to it, but we continue to evaluate and figure, because the question, I know that I have enough in assets, savings, and retirement. Some patients that we talk to, they're like, I definitely don't have that, right? Like so many people, especially when you're just in the early phases of diagnosis, you don't even know what the costs are going to be. And so I think that screens a lot more individuals positive. And it's hard to respond to 75% of respondents when they screen positive, right? So figuring out, again, to the point that that Katie made about who needs that handholding, I think we need slightly better screening items that you perhaps identify, 20 to 50% of patients rather than 75% of patients. It's a great question, though.
I actually had another question too. Because when we were talking at the end about technology and stuff, I wanted to ask if you could see a role for AI helping out with or strengthening the financial screenings. I don't know, it's probably something you guys have discussed, so.
Yeah, no, it's a great question. So I didn't go into great detail with the learning health system slide, but we have a grant where we have, we're using our, portal-based screening and paper-based screening responses. And we're actually developing that into a dashboard so we can see in real time patient responses and then screen them for these interventions. So trying to put it in one place, and that builds a little bit on AI. It doesn't use high-tech AI just yet. But what we're doing as part of that study in the third aim is we're interviewing patients and staff and clinicians about their perceptions about AI. What do you think about it? Do you trust it? Because, right, we hear from a lot of people that they're like, I don't know what this is. I'm not sure I trust this. Like, if somebody came up to you and said, you responded to, or something in your chart, your electronic health record told us that you're at high risk for poor health outcomes because of financial hardship. Like, I don't think that is how we should be approaching this. So figuring out how we do this in a way that is at least as transparent as we can be, knowing that AI is often a bit in a black box, and that we're doing it with patients along the way, is something that we're really focused on.
Thank you. I was really interested in that. And there's also one more question, and then we can go on to like the ending slides and the resources. But what do you think contributed to the lower response rate from non-Hispanic Black patients?
So we've tried to, one of the things that we struggle with is for people who are less likely to respond to the screening items, finding them for the interviews is also more difficult. So, and we're not currently, the way that the IRB is set up, we can't go to people who didn't respond and then say, hey, you didn't respond, can you participate in this interview? So we're trying to make sure that in our interviews, we're talking to as diverse a group as possible. I mean, I think that goes back to, right, historical events. I think there's good reason for people to be distrustful of the healthcare system. We're finding in our community, even in other populations now, in other racial and ethnic groups, there's increasing distrust for certain types of questions that people would ask, for data that would go into their electronic health records. We think about screening for sexual and gender preferences, right? It's good to ask, but it's also, once it's in your electronic health record, it's in there. And so that's one of the things that we're, again, and I'm hopeful with the interviews we're about to start, is understanding that trust a little bit more and how we can do this in a way that is not exploiting anyone's data, and making sure, again, that we're being mindful of the privacy and the safety, and the fairness. It's, yeah, a really important question.
Thank you. And if you guys have any more questions, you can put it in the Mighty Networks and I can reach out to Dr. Boschman. But also I shared the Mighty Networks link with you, so you can see everything posted there too if people have questions. I'm going to share the last few slides, and all the links will be in the chat. Okay, so our NJC, the phone number and the website link will be in the chat, but it's free screenings all over New Jersey for those who face barriers. They do breast, cervical, colorectal, and prostate. And thank you for attending today's session. Here's a QR code and a link. Please let us know how we did. Just the evaluation, and we really do look at these, and they help us set up our next ECHO sessions, and we are planning our 2026 sessions right now, so we'd really appreciate if you could fill this out. And all of the material, the amazing material that Dr. Boschman gave us, will be posted in the Mighty Networks community. There is a discussion page there too, so if you have any questions, please feel free to post them there. If you have any resources that you would like to share, post them there, or any events coming up. And we'll be doing nutrition and cancer next month, so make sure you register for that. Thank you again to everybody for joining. Thank you, Dr. Boschman. This was an amazing ECHO presentation. I think we all learned a lot, so thank you.
Thanks so much for the opportunity. Take good care.
Yes.
Thank you so much.
Thank you.
Thank you, everyone. We'll
Thank you
see
for
you in
joining.
December.